Well, today the discussion topic is porous diaphragm syndrome, spontaneous pneumothorax after diagnostic laparoscopy. It is a kind of very rare phenomenon, and I will be discussing a case. Porous diaphragm syndrome is a general term for a group of conditions that result in an anatomic defect in the diaphragm, leading to communication between the peritoneum and the pleural spaces. Although rare, it is an important clinical entity for anesthesia providers to be aware of, given the physiologic ramifications of the substances entering the pleural space, which can present ventilatory and hemodynamic changes. The goal of this case report is to discuss the management of an intraoperative spontaneous pneumothorax upon abdominal insufflation in a patient with porous diaphragm syndrome. Case report. A 78-year-old woman, 100 kg in weight, with a history of intraductal carcinoma, presented for a diagnostic laparoscopy due to concern of peritoneal metastasis. Pre-operative evaluation was uneventful and induction of general anesthesia was uncomplicated with propofol 200 mg, fentanyl 50 microgram and rocurium 50 mg. As the abdomen was insufflated and the patient was placed in a steep tendon-mark position, peak airway pressure rose. Oxygen saturation dropped into the 80s and end-tidal carbon dioxide quickly dropped from 40 to 10 to 15 millimeter of mercury. Upon investigation, numerous diaphragmatic fenestrated lesions were noted, creating a peritopleural communication that resulted in a pneumothorax with tamponade physiology. The hemodynamic consequences were rapidly reversible with supine positioning and desufflation. Thoracic surgery was consulted intra-op and no additional interventions were recommended. The remainder of her perioperative course was uneventful, and a post-operative chest X-ray confirmed a 13 mm right-sided pneumothorax. The patient was discharged the same day in stable condition and reported she was unaware of the defects and had never experienced symptoms. So, figuratively, it may be explained that there may be two types of figures. One is the laparoscopic image of right diaphragmatic defect, A, fenestrated lesions, and B, the right hemidiaphragm. Figure 2. Post-operative chest X-ray demonstrating 13 mm right-sided apical pneumothorax. In discussion, pneumothorax is a well-described complication of laparoscopic procedures. Etiology is commonly iatrogenic, with only a handful case of describing congenital diaphragmatic defects as a rare cause. Although uncommon, the true incidence is not well understood, as diagnoses are unlikely to be made unless there is a change in the clinical status related to the peritopleural communication. The presence of persistent fenestrations within the diaphragm consists a low resistance pathway that allows free movement of substances between the two spaces. Significant shifts of air, fluid, or other materials can lead to severe, even lethal physiological consequences. Treatment of pneumothorax is in a patient with porous diaphragm syndrome should be proportional to the degree of hemodynamic compromise. Initial measures should include cessation of pneumoperitoneum, administration of 10% fraction of inspired oxygen, FiO2, addition of positive end expiratory pressure, that is PEEP, and rapid diagnosis via chest auscultation and further assessment of hemodynamics. Termination of neuroperitoneum restores the physiologic pulmonary compliance, while the administration of increased FiO2 and PEEP facilitates pneumothorax resorption and improves the oxygen saturation. If recovery is rapidly achieved and sustained, it may be reasonable to complete the procedure with communication between anesthesia and surgical colleague. From a surgical perspective, the pressure gradient between the abdominal and pleural cavities can be minimized by reducing the insufflation pressure, limited pneumoperitoneum time, and level supine position. In the case of our patient, she stabilized with those conservative measures, allowing for expeditious completion of the procedure. However, patients who remain hemodynamically unstable may require more invasive intervention, including prompt decompression via chest tube placement or needle aspiration. Although rare, porous diaphragm syndrome is a clinical entity of which perioperative providers should be aware. Critical hemodynamic changes require vigilant supervision by anesthesia providers as well as collaboration with the surgical team. Thank you. Let me finish it today up to this much. I will come back again with other interesting slides.